So, sir, we've gone live. A very good afternoon to everyone watching us from across the globe. To all the attendees who are watching us live right now, we welcome you. Good afternoon to our moderator for the webinar, Dr. Chinmaya Pani, sir, Medical Oncologist, Apollo Hospitals, Bhubaneshwar. And very good afternoon to Dr. TARINI SAHOO, sir, Medical Oncologist, Bhopal. We welcome you, sir. So, without any delay, I would like to request our moderator for the afternoon, Dr. Chinmaya Pani, sir, to introduce our speaker before we start the presentation. Sir, it's up to you.
Thank you, Asis. Thank you, Ghansan sir, for arranging, giving us a platform to discuss. So, a hearty welcome to you all, those who are online at this point of time, and also special welcome to our speaker, Dr. T.P. Sahu, Dr. Tarin Sahu, who is a eminent senior medical oncologist currently placed in Bhopal. Actually, to say about him, he is actually a mentor to many young medical oncologists in India, pioneered in clinical trials, specifically in Bhopal, and he's a leader in clinical trial, I can say. And apart from his excellent clinical services, to me, he has a very unique position in Department of Medical Oncology, that he's very clear, outright put his point straightforward. I like this attitude of sir personally very well. There is a saying that you can borrow idea but not conviction. But I can say for Dr. T.P. Sahu, you can borrow both. So today our topic of discussion is regarding the evolution in the metastatic colorectal cancer understanding. So is being right always good, or being left always bad? Over to you, Dr. Sahu. Sir, please.
Yeah.
Very eager to listen from you.
Thank you, Chinmay. That was something which needs a little bit of 10 seconds for me to just sing down. Not heard such beautiful adjectives about myself for long, but thank you. Anyways, let's come to the topic, which is the major interest. So I can click on the slides now, or Ashish, you'll do that?
Sir, please.
Sir, I have just started it.
Yeah.
You can now click on next for each slide.
Okay, I'll go on the next slide. That's all. Okay. So the topic which was given to me, and I felt it appropriately lets me go through the data and look at the right versus left. Although the topic would have been a little more apt, I feel the right is not the right thing actually. The left is the more right. That's how I would put it across. But let's go forward and see what the data is all about. Next 20 minutes, I'll try to be brief, but just to give you a fair idea of an old topic and try to add something new to that. So there is definitely a clear polarity between the left and right, and that is very clearly seen. And the left and right, the tumor, it starts from the embryology itself. We know that the left and right are from different embryologies, and if you look at it, oh my god, the slides, it will not have that effect of the slideshow.
So slideshow, it would if you put in the effect, it will go continuously. So you'll have to change it one by one, sir.
So, but I'm not able to just the other things are not coming through. Okay, so let's go for it. Chalo, let's do it. Take it. So now, if you look at it, it's a very important thing to see that if you look at the right side, it is filled up with something which is much more bad in the biology. It is the MSI is high, the CPIMP is high, which leads to the normal high MSI. The BRAF mutations are much more common. The RAS mutations are seen much more, and the CMS1, which is actually the poor prognostic, is seen much more in the right. The left, in comparison, if you see, has more of the good prognostic features, and that's how the left versus the right story goes. And if you go forward, this is what it is all about, the molecular classification, which had put lot of emphasis some 2-3 years back, and it is classified into 4 types, the colon thing. And the CMS1 is actually the worst prognosis, the outcome is the worst, and the CMS2, which is the topmost thing, has the best prognosis. And the right somehow has more patients with the CMS1, and the left has more patients with CMS2. And if you go forward, this gives you a fair idea that if you look at the action of biologicals. You look at the CMS1, you find that the bevacizumab probably works better than cetuximab, and that's what we find in the right side. And go to CMS2, and you find the bev actually not doing good, and the cetuximab doing good for CMS2, and that's what we see in the left side. So now going forward, and let's go for the uh, what the evidence is. And if I'm sorry for that, this was a presentation which had to go on this slide. There are multiple things which was there, but let's go what the slide is coming through. This is what all of us know. There have been 3 studies: the PEAK, the FIRE, the SWOG, and the CALGB is the standout trial. If you look at the whole analysis of CALGB, it shows that anything which you do as a biological does not change. But if I look into the specific left side of the story and look at it, yes, we do find that the 7 months difference of a cetuximab versus a bev initiation means both the drugs were given, A versus B, A followed by B, B followed by A. But it shows that if in the left side, the overall survival was the longest recorded around 40 months versus around 32 months that was recorded for a left-sided started bevacizumab, and the absolute benefit was in the tune of 12%. Go forward, this was again confirmed by FIRE. The benefit of a cetuximab followed by bev or a bev, the approximation of benefit was beyond 10 months, and the benefit in terms of percentage around the same 12 to 14 to 16%. So over the trials, we have seen the quantum of benefit is better with the EGFR drug on the left side versus the bev. Now go forward and let's see the left side CRC. If you look at it, we have data that 38 to 40 months is what we're looking at for the cetuximab followed by bev, followed by third line. That's the OS data. And if you look at the bev followed by cetuximab, that's from the same trials, it is around 25 to 32 months. Let's take the maximum of 32. Still, there is a much more survival on the left side, advanced disease, if you do a cetuximab or a panitumumab followed by bev rather than the other ways. And let us find why. If you look at it, the first thing that comes out that not everyone receives the second line. And that's a very important thing which I've seen across. From the lung cancer data to the colon cancer data, it has been very clearly mentioned that not everyone receives, and the data from the colon tells that approximately 45 to 50% go on to receive cetuximab in the second line. And that is a big challenge because 50% of patients who should be eligible, 50% of patients who should be eligible do not receive a drug that has probably the most potential link benefit. And that is something we need to think what we should be initiating this. And look at the second part, what is more important. If you look at it, the patients who have the EGFR wild type, once given a cetuximab or panitumumab, the depth of response is much more bigger with these drugs than with the bev. That on the left side leads to a difference in the survival. That also is a theory, and that has come up with the data from cetuximab, and that we have been listening for the last 7-8 years. The last important thing, does something happens most importantly with the overlapping of therapies? Is there an interaction between bev and a EGFR inhibitor? Is there data to that aspect? And that is something which you look at. There are 3 trials which I can pull out: the Cairo 2, the PACE, and one more trial which shows that if you use a cetuximab and a bevacizumab or a panitumumab or a bevacizumab with a chemotherapy, and all the drugs had an oxaliplatin based chemotherapy, and compare it with any single, it was found that the triplet with dual biologicals always did worse than a single biological. Why it is so? Let us now find out. And that probably is going for a negative interaction. So if you look at it further, it is shown that if there is a role, if you look at the EGFR inhibitors, and you find that they do much better if they do not have a prior bevacizumab exposure than they have a prior bevacizumab exposure. Means if you have EGFR inhibitor which you have done and you have a bev exposure before, it does not do that well. And this is more reflected here. If the difference was more than 6 months, then the gap was, then the benefit was seen. But if you do it within a 6 months, or you do sequentially very quickly, it is trial in Japan has shown it, the trial from Japan in the Japanese clinical oncology study that they do not do that well, and there is something in the BEV which inhibits the effect of cetuximab. Now go further, you do find that once you stop BEV, many of us feel that after 1 month the effect is not there, so we do find the BEV is not there in the body. But the trials have shown that till 6 months even you find BEV which is there in the body, which could have this prolonged negative effect. So the dual effect of the both biologicals could be playing an inhibitory effect. So early start of a cetuximab post BEV failure, that's why probably has not helped. And this is shown in this graph that the maximum concentration is still there at 3 months, and even at 6 months also you do find that it does not do that well. There is still some BEV left behind in the body. So with this, we probably are getting a phenomena why cetuximab is less effective than BEV. Is there something else? Yes, there is something else. It is because if you look at it, how do we explain further? BEV also decreases tumor uptake of cetuximab 40%. This has come from a data which shows that if you have a saline, this is it, and there is a BEV, the uptake of cetuximab is much lower when there is a BEV in the body. This again tells you that the sequencing is very important. Again, BEV inhibits angiogenesis, so lesser number of the inhibitors are able to go to this tumor, and that's why less efficacy. So this is why if sequencing is to be done and someone has started BEV because there's a cost issue, I think to that effect there could be a window washout period where just chemotherapy could go in and the EGFR inhibitor comes in at 4 to 6 months of the therapy. 1 minute. Next. Okay. So now we go forward and go to what is BEV beyond maintenance effective, and is that a sequence? I do first line BEV plus chemo, then I do a BEV continuation post progression, and then I do my cetuximab or EGFR inhibitors. It also has shown the maximum benefit with the sequential era is 30 months. So the survival with a sequential and using BEV beyond progression and then at EGFR TKI, it has shown that it is around 30 to 32 months. So you are not reaching that classical 39 months which you came up with swab. So now with the sequencing, it is now well answered. For the left side with the EGFR wild type, it should be a EGFR inhibitor first followed by BEV rather than the other sequence. Cost, finances are a different thing. It's a real world, then that could be issue. But otherwise, if someone can afford the EGFR, it should be given upfront rather than late. Is there a preference for an EGFR inhibitor for the left-sided? I would tell no. Are cetuximab panitumumab the same? As per the literature, as per the guidelines, it is same. Although the data bulk is more with cetuximab and panitumumab is a close cousin, distant cousin, where the bulk of data is not there, cetuximab has the advantage of being the better, more data bulk. But yes, there are subtle differences between cetuximab and panitumumab, and all of us know the differences. What we know, more of the magnesium fall, more of the hypersensitivity, those are things you need to take care of. Now, if you look into is cetuximab a value in the right sided at all? Can we do cetuximab in the right side? Is it of a value? Definitely not in the first line. But important thing to note, can we use cetuximab for right sided tumor, CRC, wild type in a conversion therapy? What does the data tell if you're looking at conversion? What is conversion? I have an option of a surgery. My surgeon tells, okay, madam, try to give something. Let us reduce the disease, and then we try to operate. That would be a conversion therapy for me. A potentially oligometastatic trying to become metastatic, or a oligo liver deposit, and we are trying to control it. There is data to that effect that right-sided tumor, overall, if you don't use for routine purpose, BEV is probably better on the first line. But if you use for OS, no, it is not good. But if you use for conversion, and look at it, it favors the EGFR. The bulk of the diamond is towards the EGFR side. So if someone is using on a right side colon cancer with a liver deposit, your surgeon wants you to use a conversion therapy, there is no other distance, it's a liver limited disease, then probably you have a scientific rationale to use even on right side on upfront EGFR inhibitor with the chemotherapy. That's very important for us to remember. That's something which all of us remember. But the difference is it does not translate into survival. See the right hand side where the depth of the response translates into survival benefit. But here The depth of response only goes for a conversion therapy on right side, but it does not translate into a survival benefit. So that's the difference we should note, and that's also in the guidelines of ESMO. Now, coming down to cytoprotective surgery, I've already told that is one of the things we should think of. The only point I can tell you, in a young fit patient, people can even consider triplet chemotherapy without biologicals. Folfoxfury is a good option that does produce good amount of responses, and cytoprotective surgeries can be done. You have option of folfoxfury plus bev, or for EGFR wild type, you have option of EGFR inhibitors plus chemotherapy. What in a BRAF mutation? It's very, very important for us to remember that the right side is more of BRAF than the left side. And this is how a pathway goes. From EGFR, there's a RAS, then the BRAF, there's a MEK pathway, and the ERK pathway. And if you look at it, if there's a BRAF mutation, actually this pathway is not inhibited even if you give cetuximab, and the pathway is active because there's a downstream pathway which is active. And if you have a drug which inhibits the BRAF, probably you can make the pathway again not to work with cetuximab. And that is the rationale of bemurafenib with cetuximab with irinotecan. And that's why if you have a BRAF mutation, if you use a combination of a cetuximab, irinotecan, and bemurafenib, which is a which works on the BRAF pathway, and you do find there is a difference in the survival, and the cetuximab starts working, which otherwise would not have worked. And all of us know that around 8 to 10% of my patients would be BRAF mutation, would have the mutation. So that is also in the NCCN guidelines. What about, can we use something for the BRAF and can we use something for the MEK? So we can use both the inhibitors because both are in the same pathway. And if you go back and see the responses only with the BRAF inhibitor, with the bemurafenib, or you use both the inhibitors, see the response, the watershed line, everything is so nicely falling down. So probably this is the pathway which you're looking at. For a BRAF mutation, if there's something is there, we should be looking at a BRAF pathway and also looking at a MEK inhibitor along with cetuximab. So to conclude this part of mine, in left side, choose the right sequence. The right sequence at this point for a financially capable patient is a anti-EGFR followed by a VEGF anti, not the other way around. For right side, it should be an anti-VEGF followed by the anti-EGFR. If you are doing second line, you can use it. But if you use it for conversion therapy, it is a must that you have to use, and you can use an anti-EGFR because the depth of response is much, much better. Third line, just as one slide, there are two big trials. I'll not spend much of it, Encore and Correct. And we both of us know that regorafenib has shown to be superior to placebo, and this is probably the way we do it. There are trials to tell you that if you use regorafenib from 80 milligram the week 1, then 120 the week 2, and 160 the week 3, then more patients are able to tolerate regorafenib rather than starting everyone at 160. That's the only thing I felt could be appropriate. Or there are some studies to tell you that you can use regorafenib at a starting dose of 120 or 80 also. Now coming to the last part of it, for MSI high, that's around 5% of our patients in stage 4. You can use immunotherapy, but is there a role of NGS in metastatic CRC? I think it's the era of NGS. There was a big trial from MSKCC known as the IMPACT, and they did find that colon cancer, you have actionable mutations in around 40% of cases. And most important for this would be, can you increase the pickup of existing biomarker? It was a yes. New targets, yes. The new target mainly was the tumor mutational burden, the TMB. The new biomarkers, yes. Pick up already known variations with good reproducibility, yes. You can do all this with NGS, and you can do it at baseline, or preferably if NGS, people do prefer it at the later point of time. So conclude the NGS part. It's a tool to stay, and all of us as medical oncologists to be very aware of this part. NGS may not have a role in initial management, but post failure of 1 or 2 lines of standard therapies, NGS comes in, and we just cannot do away with NGS at this point of time. And the most important is that tumor mutational burden, if you find, has a potential, and some of the MSI stable disease do respond to immunotherapy. There are 2 to 3% of these patients that they are patients with high TMB scores. This is still controversial, but I think this is there. We also have to look at the HER2/neu amplification. There is good data that tucatinib and trastuzumab with the chemotherapy has found to be having good responses for patients who have this amplification. So now, to end of the day, I would just like to end off with that. For the NGS era is there, post failure of 2 lines, I think it is a time for NGS. The right versus left story still continues. The only thing is right is probably the worst part of it. Biologically, they have not been unfavorable. The mutations are much more there. The microbiome is much more worse there. So responses have been much more worse there. They have a poor prognostic value, and definitely the left has more of the RAS wild type, has a more predictive value, and they survive much longer, especially in those affordable patients who can sequence the therapy by a EGFR followed by VEGF. But for conversion, again I repeat, in the right side also you can use a EGFR inhibitor for conversion therapy. So with that, I really thank you, and thank you for patient listening. I hope I have not exceeded my time. Thank you. Hello.
Thank you very much. Thank you very much, Bhai. Thank you very much to all patient listening. So I think we should start the ball rolling for the question and answer. There are a lot of questions in the chat box, what I'm seeing. So should we start
No, I think we go to
questioning,
moderation,
sir?
and then in the question not answered, we can answer in the last. That will be a nice thing. What do you feel, Chinmay? Because I think
Okay.
moderation will cover many questions.
Yeah.
If not answered, we can always answer in the last. I feel that's a better way. Your moderation otherwise will lose lots of
Yes, yes,
steam
yes.
otherwise.
Yes, yes, yes.
I'm okay with both.
Okay, okay,
That's up to
okay.
you.
So, okay. So nothing from my side. I just want to conclude, as you have narrated from the biology point of view, from the left side and the right side. So obviously, as our conclusion comes that the left side is good than the right side. Point number one. It is those two are not only the anatomical differences. There are definitely the biological differences are much more prominent, and also one another important thing you told regarding except from the therapy, there is a microbiome differences. Also, you notice one point, there is a microbiome differences. Though from the clinical perspective, there is an ulcerated lesion in the right side and obstructive lesion in the left side, which is seen in the clinical practice when we are in MBBS, where we are thinking the left and right probably a anatomical description rather than any prognostic significance. And initially we negate that idea, probably both are behaving the same because we don't know how the two left and right side differentiate in the biology. Then later on the data came, you very nicely represent how the data came, the left versus right and right versus left. And so in the right side, there is more prominent mutation of the BRAF in comparison to left, which is, and the response to cetuximab EGFR inhibitor like cetuximab or the panitumumab is less prominent, but we can give the right point you told when it is oligometastatic and you want a response at that point of time, you can use it upfront in the first line. Otherwise, there is enough evidences to use bevacizumab in the first
Yeah,
line
I just want to
in the
I
right
just want to
side.
take one from the chat and think the rest will be covered in the
Sir,
cover. For the BRAF mutation and RAS wild, it has been asked
yeah,
by
yeah,
Hitesh that do you think citrix is my backbone? I didn't. I meant AGFR inhibitor will be the backbone. Somehow the major bulk of the data has been with cetuximab, and that has been the truth of the things. The as I told, the pathway
yes,
was there, and the pathway very clearly tell you that if you just stop on the top end because there's a mutation, the down pathway stream still continues. So definitely for the
yes,
mutation pathway, it was very diagrammatically proven and it has been proven in trials. You definitely would have a backbone which will have a cetuximab, which will have a BRAF inhibitor, which will also have a MEK inhibitor, and probably that's the
yes.
future. That's how it is going to be for this set of
That's
patients.
how it's perfectly, perfectly. And the use of the triplet backbone, what you emphasize on the BRAF positive group, and for the betterment of the response and for better the depth of the response, the role of folfoxfiri, what you mentioned, is more in the BRAF subgroup of patients, especially in the right side, which is less data on the left side. Okay, so and the sequencing you nicely mentioned the Holt meta-analysis and light chain meta-analysis, the two meta-analysis data you mentioned regarding the sequencing of the things, and of course in the second line you have to use the EGFR inhibitors in the right side, that what you mentioned. Even if you are using the left side in the bevacizumab, then there should be a gap, and then you can use the citrix because probably there is some anti-angiogenic effect of the VEGF, which can inhibit the response of the citrix. What I can understand. If you can clear this point, I'm glad to listen, sir.
Which one, please? Can you come again? Sorry.
So, if you give first line bevacizumab, then
Yeah.
the impact of the second line citriximab will be less.
Okay. So there have been 2-3 theories of
So,
this. There have been two,
logic,
three
sir.
theories for this. The sequencing theory, it has been there for last 7-8 years. And the first theory is
Yes,
that
sir.
there has been the tumors which are resistant to VEGF are partially resistant to the EGFR. That's point number one. That's why when you fail one, the other does not respond that way, and the reverse is not true. Second thing is that when you have a VEGF and you have decreased the anti-angiogenesis, the neovasculature is not there. The tumor concentration of the anti-EGFR also gets down. Number three, there's effect to that thing also, that there's trial which I showed you, the overlap trial, and the bevacizumab stays in the body for much longer time. And that is why even if you have to stop it and you start the anti-EGFR very sequentially within a month, that most of us do that, and then that's the time probably where these drugs are still there, and probably the inhibitory effect of bevacizumab on the anti-EGFR still continues. So the gap of 6 months, is it practical? Is very difficult, because many times patients progress on the second line in 6 months. So why
Yeah.
not sequence it first? While line, because if affordability is not the issue, then why not sequence in the right way? That's very, very important.
Agree. So, another important question what I want to ask you, sir, regarding the so let me ask put the questions very systematic way. So, at the upfront metastatic CRC, upfront, what molecular study you want to perform, sir?
In the upfront metastatic CRC, the definite baseline what one should do is, you should be all RAS. That's first thing, that you should having the all RAS thing, and the BRAF is the minimum what you should be doing. I do not feel
Okay.
anything beyond this at this point does help. But if you have an elderly patient who is looking at it and you are not eager for chemotherapy, and the patient is
Okay.
also not eager for chemotherapy, and you want to consider immunotherapy, then MSI might be a good step in the first line. Otherwise,
Okay, sir.
MSI comes in the post the failure of 1 or 2 lines. But after you fail 2 lines, as I told you, I picked up this NGS thing just to tell you that we have not been doing enough NGS in colorectal cancer. And this is a time we
Yes, sir.
should now start doing NGS, because you have picked up these amplifications, you will pick up these mutations, you will pick up these tumor mutational burdens, and these things do help in planning the second and third line. And look at the data for HER2 amplification. You have real good data from tucatinib, you have real
Yes,
good
sir.
data for trastuzumab, tucatinib, and the chemotherapy. And that's how it should be. Although these
Yes.
are costly drugs, but if finance is not an issue, I would not hesitate to go ahead and go for NGS post failure of 1 to 2 lines of therapy.
And I think this ASCO 2020, the Empower 155, the pembrolizumab in the first line versus the conventional chemotherapy, how the overall survival within very short time, even at the response and the 1 year survival, the 2 year survival, how it has a dramatical impact. Actually, a very changing scenario, and we are now thinking in the back end, why should not we do it before? So that's one point. Yeah.
Agree.
Another one question I have for deciding the third line therapy. Does the sidedness matter? I'm very honest question I'm asking,
Which one?
because
Does the?
for deciding third line therapy,
Mm-hmm.
third line, the
Yeah, yeah,
regorafenib data. In the regorafenib data, the Concord trial and the TAS
yeah.
data is also recently coming. And there are some concept that re-challenging the EGFR inhibitors also in the third line could be an option, because if you give the first line EGFR inhibitor, the second line VEGF, and re-challenging third line, re-challenging the EGFR inhibitor in the third line versus the Concord trial and the trial the TAS trial. Uh, so any comment on this? And does the sidedness matter for deciding the third line, boss?
The side data does not matter even for second line. I should be telling you, as per
Yeah.
guidelines, even on the right side, you can go for cetuximab if your intent is not a cytoreduction. Even on a second line therapy, you can go for cetuximab on right side. But coming to the third line, I would tell you that regorafenib has not been a very popular drug. We have been using it, but mainly we use it, and most of us have very poor experience, but fault of ours that we use it in a very extreme condition where the general condition is already very poor. But if
160.
you,
Yeah, yeah,
if
yeah.
you have
So
looked
starting
into
from
it,
82.
yeah, the regorafenib data has always been compared with placebo. Both the big data have been compared with
Yes.
placebo. So I agree that regorafenib, the point what was addressed is how to tolerate this drug better. What I wanted to point out that 160 is not the way to probably go ahead. You can start with a lower dose, and I like the data of 80 mg the first week, 120 the second week, and 160 the third week. And if you look at it and then go for this, there have been proof that more patients tolerate regorafenib better. And there are more patients on the third cycle of regorafenib. Point number two, this was an era of Concor where we did not have NGS. We did not used
Yes.
to have NGS. So I feel that that this should be on the perspective of today's time. I would do NGS for affordable class. If the NGS showed me a mutation which I can target, or I have MSA high, I'll go for these therapies better and much earlier than I go for regorafenib. That's also something. The last thing which I wanted to point out, there is data to effect that regorafenib followed by EGFR versus the EGFR followed by regorafenib, the data is
Yes.
superior to regorafenib followed by EGFR. But I would not still, even with this data, push regorafenib to second line. I would still push regorafenib down the line because these are target. If I have a target, if I have a drug, how can I just not let give it? And I do not want to give a drug like regorafenib which does not have much responses. The basic thing is disease stability with regorafenib. We have to understand that. And that is why I
Yes.
will push probably in my practice regorafenib to someone who does not have a mutation or someone who does not have the finances but would want to take a third line. That's where I'll put regorafenib.
Yes, sir. So got your point clearly. Okay, that was the post in this era, and we need to know the biology better. And of course, this identity doesn't matter in deciding the patient in the third line. Of course, you told also in the second line it doesn't matter. Okay, so okay, so should I now discuss about the question
Anything,
and answer? Which is,
anything.
okay. So because it's a very common and the many doctors and non-doctors are also there. So
Mhm.
they have asked many questions. I'll just like to put it in a very systematic way, sir.
And
So
anything.
my first question to you, sir. So my first question to you, sir, uh, does the incidence of colorectal cancer is increasing? That's
See, the
and
fact
your
is
take on
that
it, sir.
it's still the disease of the rich. If you look at the colon, I'll differ it from the rectum. If I put
Sir.
colorectal, then it are two different disease. We have to first differentiate the colon from the rectum. The rectum is more in the little bit poorer group, is more in the younger subgroup, and we do see rectal cancer in the 20s and 30s also. And even we see in the late teens also, 18, 19 years, you would have seen, I have also seen, and these patients
Yes,
usually
sir.
present in a bad way. But colon cancer, in contrast, is usually the disease of the affluent. That's how it is going through. So I feel that yes, as we accept the lifestyle, and it's a lifestyle disorder also, we would be seeing more colon cancers. Unfortunately, except for those who present with obstruction, still I feel lot of colon cancers are being cascaded in the stage 4 because it's an intra-abdominal thing. Patients do not care about it. They do not want to do test about it. They do not want to go to doctors. So I feel anyone who has a change in the bowel habits, constipation suddenly happening or diarrhea suddenly happening or bleeding, you should go and consult a doctor. Do not fear. And if you do that, you have a healthy diet, you have a lot of leafy vegetables, and you have no obesity, you take care of exercise daily. I think that's fair enough. Colorectal cancer should be, that's all you can do in the lifestyle. But yes, it is increasing as we are accepting a Western lifestyle. The Asians also are getting more of colon cancers.
Okay. Because there is a paper in the Lancet, sorry, in the JAMA in 2018, and regarding the incidence of the colorectal cancer, and they mentioned the third most common cancer in female is colorectal, apart from the breast and cervix, and third the colorectal. Actually very surprising to see, because the ICMR has published along with the Bill Melinda Gates Foundation, and it's also, it takes the fifth position, and colorectal cancer takes fifth positions in male. So that's the reason it's a very surprising thing. So that's the reason I also asked the same question to you, sir.
I think
And
head and neck
another,
cancer is
sir,
India is all about head and neck cancer. I think that will be the number one any day for me, apart from
yeah,
breast.
yeah, sir. Apart from that, so another thing, somebody is asking regarding the earlier clinical presentation and the causative factors for the colorectal cancer, sir.
I think we spoke about it. Diet, it's definitely a lifestyle disorder to some extent. There has been familial history of things of for colorectal cancer. If you have a family which has history of colon cancer and this happens in young patients, more than two or more, below 35-40, be very careful. You could have a syndrome of a familial syndrome which you could be at risk for colon cancer. That's point number one. Point number two, I think the diet plays a big role in colon cancer. That should be taken very, very seriously. And number three, what I feel is, as I told you, any change in the bowel habit should point you towards going for a colonoscopy or a test for colon cancer to exclude colon cancer.
Okay. So what is your take on, because our program director, Dr. Viswas, has written that we should in fact do all RAF, MSI, and HER2/neu in the first line setting. So your take on the HER2/neu, because you agree of all the three to
Yeah,
do. So your take on to do HER2/neu in the first line setting.
I would not. I would not. If someone does,
Like, mhm.
if someone does, he or she is not at fault. But only thing is, if I cannot do about a test, why should I do the test? I always look at it in that aspect. I have a RAS mutation, I will do something about it. I have a BRAF, I will do something about it. Because if I have wild type RAS and I have a BRAF mutant, I would not go for citriximab alone. I know what I need to do about it. If I have a MSI, in today's era of immunotherapy, I can still do something about it. But what
Yes, sir.
will I do if I have a HER amplification? There is no data that you probably first line you'll change your therapies. So I will keep it for the first line failure probably. Yes, you can do it, but will you act upon it? That's the question you need to ask yourself. And probably
Yeah.
I will reserve it for second line or third line.
Yeah, yeah. So because there was one discussion was hearing on, and they were telling the presence of the HER2 amplification will reduce the response, or there is bad prognostic criteria coming to, if you treat in any way, either you put BEV or to to the cetuximab or panitumumab, whatever way you treat, they are the bad subgroup patient and they don't respond well, and probably that was the reason that we will have a other baseline tissue. So any change in the biology happens in the metastatic site later on in the metachronous way, if the metastasis happens in the 2 year and versus the first line upfront if you do. So do you like to do the biopsy again, and what is your call on it, sir?
Probably no. Most of these mutations that happens, at least RAS and BRAF, are very basic baseline that happens well before. And you would get that data in the upfront slide blocks also. You can pull out the blocks. But MSI, definitely, if you have a stage 2 colon cancer, the data is that the MSI is high in around 20%. For stage 4, it becomes to 5%. So, and
Yeah.
for these mutations of the tumor mutational burden and other things, I would more prefer a newer sample. I would definitely prefer a newer sample. So for this newer test, I would prefer a new sample. But for RAS and BRAF, I would still go with my basic block which I've been using it during the surgery, or I'll use a block which has been there previously. For the NGS, if there's a data now coming for liquid biopsy also in colorectal cancer, I would not hesitate to do that if the new sample is going to be a little more difficult.
Okay.
I think
So from a clinician perspective, I'm asking a question. So till how old a block you are using for the NGS? Because many people are refusing to do NGS if it is more than 1 year. They told that the yield was not high and the yield was less, and doing an MSI in the PCR method is it may not be reliable, etc. and etc. So they are the explanation from the lab we got. So
Okay, let us be very honest on that part.
Sir.
I would be having a limited knowledge on few things, but to put this in perspective, if my first question which I ask is, do I need a new sample or an old sample?
Yes.
If that mutation is present at the baseline, it does not change over a period of time, I would
Point
still
well
be
taken.
comfortable with
So
the old sample. Number one.
old
Number
sample.
two, it is the quality of preservation of the tissue which matters. I feel where tissue has been well preserved, I don't feel that there would be deterioration in the quality. If 1 year is the cutoff, I'm not pretty sure. There are others who are seniors to me, colleagues. I would like to hear that point. But for me, I learn if the quality of preservation is good, if they can yield the DNA and RNA, whichever way they want to do it, I feel that's fair enough. But if
Okay.
there's a mutation which has evolved, those are the things which I want to put up, and I want to see what is there in the newer part.
Okay. Got it, sir. Got it. So basically, so point to summarize that there is no new mutations happening. Number one. Number two, the newer sample, metastatic, when metastasis happen, if you at that sample, if you have the block, you can use it, and if the laboratory wants to, sorry, sir.
Yeah, I feel there are some mutations which you need a fresh block. I'd be more comfortable with doing a tumor
Yeah.
mutational better than a fresh block. If
Yes.
there is a metastatic upfront diagnosed case, then MSI is fine for me in the whole block. If it had been a
Yes.
stage 2 colon cancer and now it is metastatic, I'll repeat the biopsy once again. HER2 new, I'm not sure, but I'll probably use a new block.
Okay.
For
Got
RAS
it.
and BRAF, I'll use the old one if it is fair enough.
And MSI and DMMR, what is your preferences? Because the options are MSI/DMMR.
I
You use the IC or the PCR base, sir?
I normally look at the four mutations in the classical way, and I look at it as the things goes. And if the ISC is fair enough, I just do it. It's a 4,000, 5,000 rupees test, and I do the MSI, and based on that, I look at the MSI high or stable. That's how I take it. And if it is to be compared in the doubtful thing, I do a fish. That's what my take is on MSI. I do it on the classical way. I do not, but the tumor mutational burden, there is data that NGS probably is better.
Yes, 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 sir. Yes, sir. So, in your clinical practice, how often you are doing NGS? Because the NGS penetration in colorectal practice is little bit less. We're a little bit hesitant, or we do it in a very later line. So, your take on this, sir?
Practically, very few colon cancers in my practice go on to third line even. So, but as the science is evolving, I remember the era of lung cancer where none of us used to do a EGFR. Few of us started doing EGFR, then we started doing it in a second line. Now we do not start therapies before we have EGFR. I'll cross everything on my table. So now I think it is a time for other cancers for us to change. And now we need to go into and now practice more of the NGS if you want to do a good therapy in patients who have the money and the pocket deep enough to afford those drugs. I think NGS is the way to go forward, not only in colon, not only in lung. It is going to be the way even in breast cancer and in a lot more cancers now.
Yes, agree. So another one questions I'm asking regarding the role of maintenance bevacizumab or maintenance rituximab. You have mentioned something in your presentation. I want more clarifications and detailed knowledge, sir.
About the maintenance bevacizumab, there's nothing as maintenance anyway. The biologicals, when you give on a palliative intent, you continue the biological therapy till progression after chemotherapy has stopped, or with a lesser dose of chemotherapy, or a single drug chemotherapy rather than two drugs. That's your modification all of us do. For the bevacizumab, there is data to the effect that once there is a progression, should you be continuing bevacizumab on progression or beyond progression is the question. You have
Okay.
data from 4 or 5 trials or the slide sets. The bright is the most common quoted thing. And there is one more data which I put up from the Europeans. We showed that if you use bevacizumab beyond progression with chemotherapy versus chemotherapy alone, you do have an additional benefit on survival event. And this is irrespective of RAF mutation. Irrespective. The only
Irrespective.
point that was negative is if you use bevacizumab first line and you use the EGFR inhibitor second or third line, at 30-40% to 50 to 55% of patients do not get this anti-EGFR who are eligible. That is the point of pushing a EGFR first, because the target is for EGFR. BEV will work across EGF across the RAS mutations. But
Yes.
for EGFR, if you are using second line with the biology, which I already told, the most important thing is 30% to 50% who are eligible do not get EGFR ever. So that is one negative point. So why not give it? Because if I can give 60% to a 100% eligible patient, I still am missing 40. And that is a worrying point for me.
Okay. Okay.
And the best
So,
data that has come from beyond progression bevacizumab is 31 months. The best
okay.
data that has come from this sequencing is 39 months. Still, I feel this is a much bigger survival.
Okay. So regarding the maintenance panitumumab or maintenance cetuximab data, there
Uh,
is a
yeah, I think all of us should agree that if I'm going a biological, I just do not stop the biological with chemotherapy. It's there with even any biologicals you do for ovary also. That it is same thing. It is at 12 to 15 months. Now the data is coming for ovary. Should we be doing beyond 12 to 15 cycles for bevacizumab? Because that is the point when the relapses are happening actually in ovary. So the point is, why should we not be using? Because the pathway is getting reactivated. So my point of using a target therapy is, ideally you should be talking to the patient. If you are responding, I will probably continue your target therapy till progression. So that anyway is include the maintenance. If you stop just with the chemotherapy and stop that, then you probably are not doing justice to anything.
okay. So with cetuximab, you want to give 5-fluorouracil or with panitumumab you want to give 5-fluorouracil capecitabine, or you want to give the single agent targeted therapy alone?
Uh, Two things here. If I
Sure.
use as a single agent for cytological response,
Hmm.
then only anti-EGFR can be used single agent. I
Okay.
do not use bevacizumab and start it as single agent because it is a cytostatic drug. If you want responses, then you have approval only for a anti-EGFR. Cetuximab can be used a third line. If I'm using it for along with chemotherapy, then I alter my chemotherapy based on toxicity. There is enough data from the oxaliplatin data that around 15 to 17 months, you have toxicities which inhibit you to use oxaliplatin. And anyway, we stop oxaliplatin. Even if we never used to use bevacizumab or even the panitumumab. So I feel the alteration of chemotherapy skeleton should be going on as per the toxicity the patient is having. So I would be comfortable using a continuous chemotherapy along with the target therapy. But if there's a toxicity, I would like to alter the chemotherapy as per toxicity.
Okay, sir. Okay. So, and somebody was asking a questions regarding the reduction of complication by the chemotherapy. So, can you give us some suggestion regarding the Optimus trial, regarding the on and off of oxaliplatin for reduction? Also, how you optimize means reduce the dose of the chemotherapy specifically, because it is asking regarding the chemotherapy complications, sir.
The two things which I want to point out here is there is data, the coin data is little more skeptical about the use of BEV and capecitabine. There's little more
Yeah.
skepticism in this world. Sorry, the use of EGFR antagonist and capecitabine. That's a
Yeah.
little bit contrast in the coin data for that. But leave that apart. Your question is very directed towards the toxic.
Yeah.
But for the toxicity part, oxaliplatin is a drug that has been looked at very, very carefully. The neurotoxicity is such severe that people have to just stop it and people just discontinue chemotherapy. So we as medical oncologists have to be very, very careful. Every cycle of oxaliplatin, especially in elderly diabetics, you should be very careful and speak about neurotoxicity with the patient. And if the neurotoxicity is there, the best thing is not to reduce the drug, but rather than stop oxaliplatin for some time and then restart oxaliplatin at a point when the neurotoxicity has gone. And that's the way the French have optimized the best use of this, the Folfox or the Capox or whatever you tell them. The second point, what you look at is when you are doing it for cytoreductive surgeries, when you are doing it for conversion therapies, the best point at that point is do not give too much. कि आपको there's a very good response happening, so I would like to give too much of that drugs and go on. The surgeon tells you have spoiled the liver, because all these drugs are hepatotoxic. The best time if you're using for conversion therapy is the time the surgeon sees the patient. Every time, every 2 cycles you monitor, and the time the surgeon tells I can operate, stop chemo. That is the time you should be letting the surgeon operate. If you push in more of chemotherapy for conversion therapy, you are going to land up in lot of liver toxicity, because most of the patients are going to have some amount of liver resected, and that is why you have to be careful when you're doing for conversion, and you have to be careful in a different aspect when you're doing for metastatic palliative intent. That's how I think that's how you optimize the things.
Okay. So another important thing, because the tolerability of capecitabine or fipronil is also an issue. So I'm just asking a very personal connotation question. What is the dose exactly you are giving the capecitabine in a metastatic setting? Also the fipronil. Your opinion, sir?
Okay, I'll be very clear how I practice. I know a lot of you do not practice that way, but I can vouch on a scientific ground that I am not wrong. I do not give the bolus 5FU. I
Okay,
do
sir.
not give the bolus 5FU. I'm very, very clear about it. For a let's say Folfox, I go for oxaliplatin 2 weekly, or I go for 85 millimeters square. I go for the leucovorin, and for leucovorin in that I go for 45 milligrams or 25 to 30 milligram per meter square. I do not give for high dose also, because there is data to aspect that high dose leucovorin versus the low dose leucovorin, there is no difference. And leucovorin adds at least 20% to the cost of the therapy. It's a costly drug. That data has been born out of necessity when leucovorin was in short supply. And then we found that low dose leucovorin is no inferior to normal dose leucovorin. Point number one, I never give the high dose leucovorin till someone has given a protocol from somewhere and wants me to do the protocol without change. Number two, I do not give bolus. I start the continuous infusion 44 hours after I finish my leucovorin and the oxaliplatin. So these are the two things which I do, because what I found is scientifically you are not compromising on any efficacy data. But the bolus 5FU leads to more of hematological toxicity. So that is the reason I've altered this in my practice, and I'm pretty happy. My patients are pretty happy with that. For capecitabine, I've aged probably. I've slowed down. So I feel that capecitabine initially I used to give at the standard dose, no dose reductions. I used to give it. Patient used to come with a lot of hand foot. What I normally do is I normally give now at around 1000 per meter square. And if they do not tolerate, come down to 850. And if they tolerate, I go up to 1250. That's how my capsuline practice has been. I find there are 30 to 40% patients who do not have any problem with any dose, but 30-40 who do not tolerate even 50% of the dose of capecitabine. So that is the individual patient. You talk to the patient, talk to them, talk about hand-foot syndrome. They will understand. They will come down, and you alter the dose. That's how I do for this. So I'm been very candid about what I do in practice. I know few things would not be agreeable to few of the oncologists, but there is data to whatever I told in this thing.
So regarding the DPT mutation analysis in the loose motion, so when exactly you do? Just
I don't do. I'm sorry. I agree. I should be doing much. I don't do.
Not an issue. So my last question is regarding the prognostications of the metastatic colorectal cancer. Does it uniform if it is liver limited, if it is ascites, if it is multivisceral? So just a close-up remark on that, sir.
It's basically 40 to 40% of our patients do come with an advanced disease, and I think tumor board is the answer. You should have a oncosurgeon. You should have a hepatic surgeon. I'm very clear about it. I understand it's a missing faculty in many of the tumor boards, because there is
Yes.
some data from UK, and I can quote the data that those patients who were considered inoperable for liver disease by surgical oncologists, when they went to a specialist hepatic surgeon, they were considered to be operable. And all of us know that metastectomy in a complete way is the best way to cure this patient. So the tumor board should consist of a hepatic surgeon, should consist of an oncosurgeon, medical oncologist. Radiation have limited role, pathologist and a radiologist. And you should have a facility for volumetric MRI and CT scans, because you need to look at the liver functionality. If that is all done, I feel that is the best place to get treated for the advanced colorectal cancers, because you would be getting the optimal therapy, you will be getting operated at the right time. You, if you go to a single alone center, if the medical oncologist is not letting you go, the response is just lost. You would lose the window which you get between for surgery. You are pushing lot of target therapy, you might get a progression. So I want to tell you that this is the vital point. You should get a good team. If you don't have a team, you should build up a team, at least virtually, because now everything is virtual. So you can have a team even virtually, and that's how it should be done.
Agree. Sir, in ascitic group, specifically the bad subgroup of patient where the initial presentation, though we see very less percentage of patients, what about them, sir? What is their prognostic outcome or overall survival?
Should I tell you, I've experienced two patients of mine, and both were young patients. Both patients had only ascites, cytology positive, no other disease anywhere, just operated. Cytology were positive during surgery. We just went for chemotherapy, and I can tell you, I've lost both the patient within 2 years of relapse, and they relapse very fast. Prognostically, it all depends what age the patient is in. And I feel once the ascites comes in, it is more of a palliative intent, although you can operate, but they do not do well. I don't know what your experience, Chinmay, you can add on to that.
Sir, agree, sir. Specifically, those who are the peritoneal deposit, they behave very badly. The response is bad, and usually the ascites associated with the EGFR. Yes, sir. EGFR, the mutant subgroup usually is have, and so also the BRAF positive group.
One patient of mine which I lost last month. I can tell you that I did an NGS for that lady because she was an affordable class, well-off family. And she went on to receive panitumumab. She was RAS wild type, BRAF non-mutant. And to tell you that she had TP53 mutation. I think that is also very important. When you start doing NGS, you get these mutations. And when you look at the mutation, then you understand why this has failed so much. None of the chemotherapy worked. And I thought, why? You normally see responses happening. You normally see stable disease happening. She never had anything of that. And that's something which you feel very bad. So NGS also helps you in this part also.
Yes. Yes, sir. So thank you very much, sir. It's already 4:30. Our time limit was from the 3:30 to 4:30. We started almost in 3:31, and we're almost about going to finish in 4:31. So it's a very informative, elaborated, I can say, elaborated informative session by Dr. Sahu. And I told you in the first remark that you can borrow idea, but not conviction. And he is a person who will allow to borrow you the idea and conviction. This is my concluding remark. So thank you all. Over to you, Ashish. You can.
Thank you, Akshay. Thank you, Ashish. Thank you, Chinmay, for those very nice words, and it meant a lot to me. And thank you. And I would love to be a part of more meetings. And thank you. It makes me learn.
Thank you, sir.
Thank you.
Thank you very much, sir. We'll meet you again, boss.
Thank you very much. Thank you so much, sir. So before we end it, sir, I have a short announcement to make, sir. For all the attendees that are watching us live, we have posted on the top of the chat box the procedure of how you can get your e-certificates for the webinar. And for all who have registered, everyone will receive an email in which you will be provided with the link for the feedback as well as the link for downloading your certificates as well. So nobody needs to panic about how to get your e-certificates. So you'll be getting it very soon. And we promise everyone that we'll be coming up with more interesting webinars in the near future as well. So before we wrap this up, thank you so much, Chinmay sir. Thank you so much, TARINI sir, for this beautiful and informative webinar. And we would love to work with you in the future as well. So thank you everyone. Thank you everyone who's watching us live. Thank you, sir. For till the next time.
Thank you all. Thank you, Ghanshyam bhai, who is absent. I think is online. Thank you very much, sir. Thank you. Bye bye.